Have you been recently diagnosed with prostate cancer and you are not sure what treatment you should choose? Have you been given multiple choices by your urologist, including surgery, radiotherapy, or just monitoring? Do you feel lost as to what are the pros and cons of each treatment and what is best for you? This video focuses on the results of one of the largest UK randomized trials called the PROTECT trial, comparing 3 different treatment options for confined prostate cancer, including surgery, radiotherapy, and active monitoring. Many urologists in the UK and worldwide use the findings of this study as a reference to advise their patients regarding which option to choose. We will go through the results of the trial and the impact of each option on the odds of dying from prostate cancer or from any other cause, so that you could be better informed when choosing what treatment option to go for. If you're ready to go through the results of the trial, let's dive in. What is the PROTECT trial? Between 1999 and 2009 in the United Kingdom, 1,643 men with a diagnosis of a confined prostate cancer were enrolled in a trial to evaluate the effectiveness of different treatment options, with 545 randomly assigned to receive active monitoring. This entailed regular PSA blood tests, with further actions if there were any signs that the cancer is progressing. 553 to undergo prostatectomy, which is a surgical removal of the prostate, and 545 to undergo radiotherapy, which is radiation to eliminate cancer cells. Both surgery and radiotherapy are also called radical treatments. When was the decision for active monitoring reconsidered? If there was an increase of at least 50% in the PSA level during a 12-month period, or any concern on the part of the patient or clinician, the decision for active monitoring is reconsidered, and a review is triggered, with management options that included continued monitoring or radical treatments. What are the main results of this trial? At a median follow-up of 15 years, the results were compared with respect to death from prostate cancer, which was labeled the primary outcome, and death from any cause, metastases, disease progression, and starting hormone treatment. These were all labeled the secondary outcomes. Let's talk first about death from prostate cancer. Overall, there were 45 deaths attributed to prostate cancer over 15 years. 3.1% occurred in the active monitoring group, 2.2% occurred in the prostatectomy group, and 2.9% occurred in the radiotherapy group. There was no significant difference in the rate of death due to prostate cancer among the 3 groups. The good news was that approximately 97% of patients across the 3 groups survived prostate cancer 15 years down the line. And as a reminder, these were all cases of prostate cancer that were confined to the prostate. Let's talk about death from any cause. Death from any cause occurred in 356 men, which is around 21.7% of the entire group, and this was evenly distributed between the 3 groups. The leading causes of death were heart or lung disease in 31.8% and other cancers in 51.6%. Secondary outcomes. Metastases or distant spread from prostate cancer. The active monitoring group had higher metastasis rates at 9.4%, compared to the prostatectomy group at 4.7% and radiotherapy group at 5%. The need to use hormone treatment. This is often used when the cancer has spread outside the prostate in the active monitoring group, or when there is evidence that it has come back in the surgery or radiotherapy group and no other salvage options are suitable. Long-term therapy with hormones was highest in the active monitoring group at 12.7%, compared to the prostatectomy group at 7.2% and radiotherapy group at 7.7%. Disease progression. There was an increase in the incidence of local progression, which means the disease advancing beyond the confines of the prostate in the active monitoring group at 25.9%, which was remarkably higher than the progression in the prostatectomy group at 10.5%. or the radiotherapy group at 11%. How many patients actually have active treatment with either surgery or radiotherapy? By 15 years, 92.5% of the radiotherapy group and 90.4% of the prostatectomy group underwent treatment, compared to 61.1% of patients in the active monitoring group. 24.4% in the active monitoring received no active treatment or hormone therapy. In other words, these patients spared themselves the side effects of surgery or radiotherapy for 15 years without dying from prostate cancer. What's even more interesting regarding these men who remained on active monitoring for 15 years without any treatment, that at the time of the initial diagnosis, 12.8% of them were considered to have intermediate or high-risk prostate cancer, and 10.5% had Gleason, grade group 2 disease or higher, which is often considered as significant cancer. Metastases or spread outside the prostate in the active monitoring group. The higher incidence of metastatic disease in the active monitoring group at 10 years was anticipated to result in higher deaths of prostate cancer at 15 years. But surprisingly, this was not the case. Among the 40 men in whom metastatic disease had been diagnosed at 10 years, the risk of death from prostate cancer was lower among those in the active monitoring group, 13.6%, than in either the prostatectomy group, 25.0%, or the radiotherapy group, 70.0%. Conclusions. The percentage of patients who survive a diagnosis of confined prostate cancer is high at around 97%, with no significant differences among how the cancer was initially treated, be it monitoring, surgery, or radiotherapy. Active monitoring carries higher risks of metastases and disease progression, but does not impact long-term survival. Radical treatments like surgery or radiotherapy reduce disease progression, but do not improve the percentage of patients who die from prostate cancer compared to active monitoring, which entails offering treatment only when there is evidence of disease progression. Active monitoring offers a less aggressive yet effective management strategy for many, while radical treatments should be reserved for cases with clear indications of higher risk. Enhanced diagnostic precision and long-term follow-up are critical to optimizing outcomes and refining treatment strategies. Therefore, a patient-centered approach, considering individual preferences and balancing treatment harms and benefits, is essential in managing localized prostate cancer. This is the end of the video. In the next video, we will dive into what factors influence the patient's choice of treatment between surgery, radiotherapy, and monitoring for a confined prostate cancer. I hope you enjoyed this video and found it educational. If you did, please consider liking, sharing, and subscribing to the channel to help its growth. See you in the next video.